Hi everyone, I'm Conrad Fischer, Professor of Medicine, Residency Program Director, and whether you're here for Step 1, Step 2, Step 3, Level 1, 2, 3, we have what you need to be able to get all the pharmacology and treatment questions right. What's the best initial therapy? What is this therapy? What's the mechanism of action? Step 1. What's the efficacy and what's the adverse effect? Because adverse effect is on everything. And you might say, what are you doing the ophthalmology section? And the answer is I'm doing the ophthalmology section to prove to you that you should be able to, by the time you finish medical school and internship, handle the half a dozen most common diseases in anything. And you don't need a subspecialist level of knowledge. You need just what you need to answer those questions and take care of humanity. Part of the reason I love doing ophthalmology is because the standard of care changes every 10 years or so in everything. Even eyeglasses, which you used to have to go and see an ophthalmologist or optometrist. Now you just walk in and buy them over the counter. So here, the most important thing for you is red eyes, because this is an ophthalmologic emergency. Now, if it said photophobia, burning with the light, blinded by the light, photophobia would mean uveitis, red eye, and photophobia alone. Uveitis, best initial test, most accurate test, slit lamp, use steroids, slit lamp, use steroids. Oh, was there trauma? It doesn't say anything about trauma. Does it say anything about contact lenses? It doesn't. Corneal abrasion, fluorescein staining, and close your eyes. Ooh, the red eye. Is it uveitis? Is it conjunctivitis? Is there a purulent material, which is to say pus? No, but here's the key to the diagnosis. Midpoint non-reactive, midpoint non-reactive. Do you expect people to say it's a hard knock life for us, a hard knock eye for us? No, what are you doing? You're making your diagnosis by poking people in the eye? Like the Three Stooges. So this one with midpoint non-reactive pupil, this is glaucoma. So the questions here for pharmacology in the Get Pharm, which is either the book of Proverbs, with all of thy getting, get wisdom. So we call it Get Pharm. Or Olivia Newton-John, let's get physical. What's the best initial therapy for acute angle closure glaucoma, and how do they work? What medications? Well, anything that dilates the pupil, anything that's anticholinergic, anything that's anticholinergic that dilates the pupil, because if you dilate the pupil, you block the canal of whose canal? Schlemm's canal. So you want to constrict the pupil and open up the canal of Schlemm so things can drain out, so we don't crush your optic nerve, because that's what glaucoma is. The ciliary body, that's where aqueous humor is made. That's where aqueous humor is made. Vitreous is down under. And aqueous humor is made in the ciliary body, and it should drain. And that is our wonderful artist's rendering of aqueous humor being blocked. So anything that dilates the pupil, blocks the canal of Schlemm, constricts the pupil, opens the canal of Schlemm. Now, the interesting thing about the treatment for acute angle closure glaucoma is that beta blockers, and I don't think it's that important that you know which beta blocker, but it's not the beta blockers that we use for the heart. For instance, metoprolol, atenolol, carvedilol, labetalol. That's not which ones we use for the eye. We use timolol, betaxolol. So anything that uses beta blockers will increase the drainage and also decrease production. The production of the aqueous humor is also like cerebral spinal fluid, and cerebral spinal fluid is made with carbonic anhydrase. So we can use carbonic anhydrase inhibitors, derivatives of acetazolamide, dorzolamide, anizolamide to stop the production. Beta blockers stop the production. Pilocarpine increases acetylcholine. Will acetylcholine constrict or dilate? Will acetylcholine constrict or dilate? Acetylcholine will constrict. Beta blockers will constrict and decrease production. So timolol, cute. is not used systemically. Timolol is eye drops. It decreases the production of aqueous humor. Do I like the fact that also beta blockade, sympathetic stimulation dilates the pupils, dilates your bronchi, dilates the pupils, dilates your bronchi, dilates the blood vessels in your skeletal muscle. Ooh, beta agonists dilate. Beta blockers constrict and decrease the humor. Apraclonidine, let's keep the key word there on clonidine. Clonidine, for blood pressure medication, is essentially acting alpha-2 agonist. Pain in the ass, isn't it? It's an agonist. So if it's an agonist for alpha-2, it also constricts the pupil because alpha-2 shuts off sympathetic production. And so alpha-2 shuts off sympathetic release and also decreases in clonidine the aqueous humor. But it constricts the pupil, decreases production, and pilocarpine. Pilocarpine increases acetylcholine. The same way if it's myasthenia gravis, we use neostigmine, pyridostigmine, edrophonium. This is like neostigmine for your eyeballs. And carbonic anhydrase makes aqueous humor. So for acute angle closure glaucoma, IV carbonic anhydrase inhibitors. And at the end of the day, if it doesn't work, you got to shoot a hole in their iris so it drains out. Now, glaucoma worldwide is one of the top 3 causes of blindness, and depending on income, in some countries, the most common cause of blindness was glaucoma. Let's find some positivity. The most common cause of blindness worldwide for many years was trachoma, chlamydia trachomatis. And an infection would blind you. The child would get trachoma and their cornea would rot off and you go blind. The reason that glaucoma is a cause of blindness in resource-limited countries is because you have to have the medications, often need to be refrigerated, but you need to have access to daily medications to constrict your pupil and decrease aqueous humor production. You see, it's not like cataracts where you can go in and operate on 20 kids in a day and operate on 30 kids, operate on 20 and 30 and get rid of those cataracts and you're cured because there's no real good cure for glaucoma. I mean, you can put a hole in their eye with a laser, but it's not great for the general population. There's our canal of Schlemm. We want to open that up so you can increase the drainage and stop having the pressure. Canal of Schlemm's, you want to increase the drainage out there. There's the ciliary body, and that makes the aqueous humor, and it flows through, and the iris, and we want to constrict the iris, constrict the pupil so it opens the canal of Schlemm. Now, prostaglandin analogs increase drainage out of the canal of Schlemm, but it doesn't do really well in acute angle closure glaucoma, but prostaglandin analogs are fantastic for routine management. That's why they can be used for chronic management. Glaucoma is like essential hypertension of your eyeball. Why does it happen? It happens. What are you going to do? Decrease the pressure. So we have a combination of drugs that increase the drainage and decrease the production. Increase the drainage. Acetylcholine constricts the pupil. Prostaglandin analogs also open the canal of Schlemm and decrease production. And there you have, and in the middle we have a drug that does both of those things, the clonidines. 1, 2, 3, 4, 5 classes of medications for glaucoma. You see how I said that everything changes in ophthalmology every 10 years? How much of this existed 20 years ago and 25 years ago? Very little. Why is it wonderful to go to medical school? Because then you can learn how to do miraculous things like preserve the sight of people by the millions so they don't go blind. Anything that's anticholinergic like atropine will dilate the pupil. Antimuscarinic drugs, tricyclic antidepressants will dilate the pupil And anything that dilates the pupil makes it harder for the aqueous humor to drain out. And this is as much a question about dangers, primum non nocere, which is first do no harm, nociceptive, nocere, 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 the Latin for harm, to hurt, where we get nociceptor from. And that's just as important. So in this course, we're going to be confronting what is this drug, what's the mechanism, what's the adverse effects. You know that for each drug, and you're going to be golden. What's the most common cause of blindness in the United States, Western Europe, so-called developed countries? We should say countries with a lot of resources. What is the most common cause of blindness? Now, I'll tell you what the most common wrong answer is. The most common wrong answer is saying diabetes. Diabetes was the most common cause of blindness. It was, but we're doing so much better in diabetes. Do you know that the first couple of years I taught USMLE, I actually had to get up and say, we don't know that controlling sugar is proven to protect your eyes, your heart, your kidneys. You think that's been known forever, but it's not. It took decades to prove that controlling sugars actually protect your eyes. Wow. Wow. But then again, the first 5 years I did this, 10 years I did this, I had to say that beta blockers were contraindicated in congestive failure because they're negative inotropes. Wrong. It's good to be wrong. Good to be wrong. Patients come in with dry macular degeneration, wet macular degeneration. Wet is less common, dry is more common. But wet, meaning proliferative, makes you blind more often. So it's less common, wet, but more dangerous. This is the most common cause of blindness. The most common cause of blindness is macular degeneration. This is called an Amsler grid, A-M-S-L-E-R. Amsler grid. You lose the center of your world. You lose the center of your world. This is the most common cause of blindness in developed countries, resource-rich countries. You lose the center. Oh, terrible, huh? Yeah, macula, you're losing central vision. So diabetes is no longer the most common cause of blindness. That means that macular degeneration is. It's not that macular degeneration became more common as a cause of blindness. It's that diabetes became less common as a cause of blindness. The optic nerve, drusen building up, gummies over there, and you're ruining your macula. Amsler grid, because you want to be able to have people screened. You want to be able to screen people because then you can treat it. But macular degeneration, after all, at the end of the day, what can you actually do to treat it? The most common wrong answer, of course, is saying nothing. But did you know that the complement system helps to destroy the macula? The complement system, C3, C5. Part of macular degeneration is vascular endothelial growth factor, VEGF. I'm still waiting for VEG-E and VEG-G, VEGF. And for dry, it's complements. Pegcetacoplan. I know, if I wasn't me, I might not have heard of it either. But pegcetacoplan works for paroxysmal nocturnal hemoglobinuria. Pegcetacoplan stops hemolysis, but it also stops you from going blind. Attacking your red cell, attacking your eyes. Wow. Avaxin-captid. Avaxin-captid also is a complement inhibitor. We have eculizumab, ECU-lizumab. Eculizumab is a monoclonal antibody against C5. It's used for PNH. Eculizumab, a monoclonal antibody against complement C5. Stop your hemolysis in PNH. It works for stop the destruction of myacetylcholine receptors in myasthenia gravis. eculizumab. Stop the destruction of red cells in hemolytic uremic syndrome. A whole new world, a new exciting point of view. So many new things to learn, so many new ways to help people, so many new ways to preserve the sight of the blind. Lasers help for diabetes. Laser helps for diabetic retinopathy, but not for macular degeneration. We give them vitamins. Do the vitamins for dry really stop the drusen? That's a photomicrograph of a retina. This is the choroid. The choroid is the vascular bed upon which the retina. These are rods and cones. Isn't that amazing? This is the retina. And this is the choroid. The choroid is a ball or bundle of blood vessels upon which the retina sits. To the end, the vitamins, the antioxidant vitamins help. Who could say no to some vitamins? Eat your dinner, honey, and take your Fred Flintstones. Can't hurt, might help. But wet macular degeneration. The most common cause of blindness in the United States, and remember, I hate to be ethnocentric, but it is a USMLE. If I were studying for an exam in a place that had more tropical diseases, I'd have different diseases in here, but this is not what we're studying for, right? So I don't want anybody being offended. Not for bad reasons anyway. I want you to be offended for the right reasons. So wet macular degeneration proliferates because it's making huge amounts of VEGF. Now, VEGF inhibitors, not only do they stop 97% of macular degeneration, stop it, it actually reverses it in a third. 1/3 of people restore 3 lines on their visual acuity testing. You know, when they have the big E at the top and then the small and the small and the smaller and the visual acuity. 1/3 of people have restoration, improvement in vision. Now, what's different about faricimab? It's a monoclonal antibody. They're all monoclonal antibodies, including the unpronounceable aflibercept. Scooby-Doo. But faricimab is VEGF and an angiopoietin. We have erythropoietin for red cells. We have GCSF and GM-CSF for white cells. We have romiplostim and eltrombopag, avatrombopag for platelets. And now we can inhibit the growth of blood vessels in your eyeballs. 97% stopping. That's why we do the Amsler grid to find when you're having macular degeneration before it destroys your vision so you can get these injectable medications before you lose your vision. 97% stopped, 1/3 of vision is restored. Amazing. Ooh. Normal. 97% of vision is there near the macula. You notice how there's almost no blood vessels there? Diabetic, vitreous hemorrhages, flame hemorrhages, neovascularization. And what's the best initial therapy? What's the best initial therapy for diabetic retinopathy? I know. Control your sugar. I got it. I'm all for controlling sugar. Target A1C less than 7%. I've got it. Beautiful, isn't it? Angry Mars, angry planet. That's macular edema in there. What are we going to do for this angry planet inside your eyeballs? The wrong answer is laser. We do lasers sometimes if you can't get the VEGF inhibitors, because the VEGF inhibitors need an injection. And you know, there are places where basically people jump in once a month and they bounce in, they shoot up 50 eyes and move on. But VEGF inhibitors, if you can get them, are better than laser photocoagulation. So in the miraculous world of ophthalmology, you can restore sight to the blind. You can put an implantable defibrillator and raise the dead. 90% less people live in mental institutions compared to 40 years ago. Cast out demons. You can cleanse leprosy with dapsone and rifampin for $2. Cleanse lepers, raise the dead, cast out demons, restore sight to the blind. Wow. Very miraculous. Routine miracles. That's a very further. Oh, let's look at the normal one. Let's look at a normal one. Oh, see the normal? Sharp, 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 sharp. The cup is in the disc. The cup is in the disc. Sharp margin of the disc. Sharp margin in the disc. But now we got a fuzzy. Why is that so fuzzy? It's not papilledema. It's fuzzy because this is what optic neuritis looks like. Optic neuritis. Now, optic neuritis is a fuzzed out optic nerve presenting with monocular vision loss over a couple hours to days, which is how you tell it apart from an artery and vein occlusion. Because artery and vein occlusions happen like that. Artery and vein occlusions is just like a stroke. Amaurosis fugax, the TIA of your eyeball, that's a stroke. Retinal detachment happens quickly. Retinal detachment happens in a few minutes, an hour. And retinal detachment, the curtain coming down, the window shade coming down. But this is fuzzy vision. The other thing is, it often, optic neuritis and trigeminal neuralgia, optic neuritis and trigeminal neuralgia, this is how multiple sclerosis presents with first in a third of patients, optic neuritis and trigeminal neuralgia. But here's the thing that's really weird. It's hard to understand that it's an optic neuritis, but it actually hurts when your eyes move around. So the eye is inflamed and hurts when you actually have extraocular motion. So an afferent pupillary defect means when I shine a light in the affected eye, no constriction. When I shine a light in the other eye, I get constriction. The swinging flashlight, yes, afferent pupillary defect. And so the afferent pupillary defect means that the opposite eye will constrict the pupil. Classic, classic. But here's the two things. I think that most people will know that because it's an MS, multiple sclerosis, and because it says itis, inflammation, not infection, inflammation, not infection, I think most people will know it's high-dose steroids. I think 70 to 80% of people get the treatment right. But here's the kicker. Eye pain with movement is hard to understand. But here's the thing. If you have an afferent pupillary defect and you look in the eye and you see this defect and you see the defect and you see the defect, okay, you're golden. But what happens when you have this presentation but you don't see anything in the majority? That's how you're going to save someone's vision. So one of the greatest enemies of your preparation for this test, these tests, because the Pharmacology Get Pharm course and the Pharmacology question bank that we have are good for step 1, 2, 3, frankly, even internal medicine boards. On step 2, 3 in the IM boards, you pay more attention to the therapeutic question. On step 1, you pay a little more attention to the mechanism question. It won't kill you and hurt you to know the mechanism of how things work. But the major enemy you have is voices in your head that are telling you what you're learning is bullshit. And it's not true. Because not only will people live and die based on how much you know, they will go blind if you screw it up, and they will see. If you know that the majority have a normal appearing eye, and what's the next step is equal to what's the most accurate test? Not actually, I'm fooling you so you're wrong. Do you think I need people like you out there to be wrong? You think I'm some sort of shallow, self-centered, weak-egoed narcissist? That I need little people like you to be wrong just so I can feel important? Absolutely. But if you understand this, that you can have visual loss, eye pain, you know that it's an afferent, and you're like, man, that's optic neuritis. But you don't remember that the eye looks normal in 2/3. You're going to forget to order the MRI. And there's the MRI with an inflamed nerve, 2/3 you can't see anything because it's behind the eye. Retro, behind the eye, bulbar. So that means if you see this presentation, the next step in the management of this patient is clearly to give steroids. Wakey, wakey. Temporal arteritis, head pain, headache, tenderness, high sed rate, give steroids. Don't wait for the biopsy. Facial palsy, give the steroids. Sudden loss of hearing in one ear with tinnitus, vertigo, nystagmus, hearing, tinnitus, vertigo, nystagmus, hearing, tinnitus, vertigo, nystagmus, hearing, steroids. Because it preserves the eyesight, the face, the ear. What's the next best step? And they get an MRI or give the steroids? Give the steroids. Temporal arteritis? Give the steroids. Labyrinthitis? Give the steroids. Facial palsy? Give the steroids. Optic neuritis? Give the steroids. Because, okay, granted, a little bit more step 2 and 3, you are big enough and large enough. Walt Whitman says, I am larger and better than I thought. I did not know that I held so much goodness. My heart is so small. How can this great love be inside of me? Love of medicine, love of humanity. For where there's a love of medicine, there's a love of humanity. My heart is so small. How can this great love be inside of me? Look at your eyes. They are small, but they see enormous things. So says Molavi Mevlana, also known as Rumi. If you learn what I'm saying today in this course, if you stop this day and night with me, you shall possess all that you need to save humanity, protect them, restore sight to the blind, preserve their hearing, sudden loss, hearing loss, unilateral hearing loss, tinnitus, vertigo, nystagmus, hearing loss, steroids, facial palsy, steroids, temporal arteritis, steroids, and optic neuritis without waiting for the MRI. But aren't you worried about an unnecessary dose of steroids? No, it's like going out and binging on your credit cards for one night, knowing it'll be paid off next week. I'm not worried at all. I'm worried about you feeling the sense of the miraculous, that as the Sufis say, that the grace of God is like invisible rain coming down all the time. If you could see it as I see it and feel as I feel, you will have an endless amount of energy to absorb and do what you need to for this suffering humanity. And as a byproduct, you'll get your 270 on step 2.